Why is it that humans get heart and vascular disease? This topic is critically important to understand for anyone who's interested in living a longer life and a healthier life, because they're the #1 contributor to death in industrialized countries. That's why I'm very pleased today to have on with me Dr. Tom Dayspring, a clinical lipidologist, a physician, a doctor who is absolutely unparalleled in his knowledge and contributions into this space. Dr. Dayspring's delivered over 4,000 lectures worldwide. He is the recipient of numerous prestigious awards. He served as the editor for one of the highest ranking journals in this space, and he's authored a huge number of publications that continue to serve as the educational basis for doctors throughout all stages of their training. Most importantly, I think in this talk, you'll discover that there's a huge amount of information that we know about this disease process, but more importantly, there's a huge amount that can be done to lower one's risk of heart and vascular disease. So with that, I hope you enjoyed this conversation with Dr. Tom Dayspring. Tom, thanks for joining us. Really appreciate you coming on.
My pleasure, Nick. You know me. If you want someone to spin lipids, I'm the guy.
That's for sure. I'm really excited to have you on today. There's a lot that we can talk about, but I wanted to start more broadly. Specifically for the audience, kind of starting more with the general concept of why do humans get atherosclerosis or plaque buildup in the arteries? Why does that happen to us specifically? You know, what age does it happen at? Are there different risk factors? And kind of go into more narrow subjects after we cover those.
Sure, and it's kind of interesting. I was working on a presentation I'm going to be doing in a month or so, and one of my slides, atherosclerosis is not something limited to the 20th century. 4,000 years ago, they've gone back and looked at some of the mummies over there in Egypt, and some of the mummies had atherosclerosis. Now, obviously, those folks had very different diets than us. So that tells you if they had atherosclerosis back then and we have it now, genes are involved. Human genes are certainly part of the culprit as to who gets this or not. But there's one simple rule for atherosclerosis. If you have cholesterol in your artery wall, you have the disease atherosclerosis. And if you do not have cholesterol in your artery wall, you do not have atherosclerosis. So the fact that X amount of people get cholesterol in their artery wall, that is the cause of atherosclerosis. Now, the complexity is trying to figure out how did that cholesterol get into the artery wall, and once it's in there, what else is it causing to sort of expand and ultimately cause arterial disease of clinical significance. So it's a sterol-driven disease. And by far the most prominent sterol that floats around our plasma is cholesterol, although there can be others under certain circumstances. So the mystery to atherosclerosis is scratching your head and saying, how the heck does cholesterol get in our artery walls or in the walls of those mummies 4,000 years ago? Now, cholesterol, of course, is a lipid. There are many other lipids. Most people perhaps know triglycerides or fatty acids as lipids, and might be hard-pressed to name any other lipids unless they've studied them in some course in high school or college or something. So, but what everybody should know about lipids is their distinct characteristic is they are organic molecules not soluble in water. And this created a dilemma for evolutionary forces over time, because the only way lipids get from here to there in the human body is they have to use the blood system, the plasma, to move around here, there, and everywhere. And of course, most people know or should know that plasma is what we call an aqueous solution. It's pure water. Lipids are insoluble in water. Lipids are soluble in alcohol or other solvents, but not water. So how the hell do lipids traffic throughout human plasma, human blood vessels? So I always tease that evolution had to quickly invent a water-soluble lipid transportation vehicle. And that was so easy because evolution knew peptides, proteins, are very water-soluble. So if we could somehow combine proteins and lipids, we actually might construct a lipid transportation vehicle that could deliver lipids where they got to go. And of course, I've just described what a lipoprotein is, a collection of lipids and a protein. And the protein has to have the ability to surround and provide structure and stability as well as water solubility to an oil droplet, which is a group of lipid molecules. So many of our lipoproteins only have one big protein attached, but they could be carrying 20, 30,000 lipid molecules. So the proteins that do have the ability to bind to lipids and create these particles are called apolipoproteins. Before they bind to lipids, they're apoproteins, but once they adhere to lipids, you have apolipoproteins. You really have a water-soluble transportation vehicle. If we look at the human lipoproteins, you can divide them into two classes, and they're classified by the structural proteins that are on them. So in the one family, there's just one big, gigantic peptide that enwraps these oil molecules, lipid molecules, and it's called apolipoprotein B. The other family of lipoproteins has no ApoB on them. Their structural protein is apolipoprotein capital A, not little a, capital A. And those are your high-density lipoproteins. The ApoB family consists of a collection of particles that have different densities. And of course, densities are determined in a centrifuge. Do they sink or float when subject to centrifugal forces? So the very low density lipoproteins sort of float. The low density lipoproteins sink a little bit, but more so than the intermediate density lipoproteins. And of course, at the bottom of the centrifugal tube is the high density lipoproteins. From that description, you want to what makes a particle float or sink, creating its buoyancy or density. It's the more lipids they carry, the more it floats. If it's just proteins carrying very few lipid molecules, they sink. So obviously, LDLs carry less lipids than do VLDLs, and HDLs carry far fewer lipids than do LDLs. So back to what causes atherosclerosis. Obviously, a lipoprotein has to leave plasma, enter the arterial wall by passing through the one-cell lining called the endothelium, and get deposited in the artery wall. And it is the ApoB family that have that potential. The ApoA1 particles can actually go in and out of the artery wall. They don't get trapped, so they don't contribute cholesterol to any plaque formation. But the ApoB particles, once they go in, they rapidly adhere to sort of arterial wall connective tissue called proteoglycans, and they're stuck. Like I used to joke, a fly to fly paper. That fly ain't getting away. Once those ApoB particles are in your arterial wall, they're stuck there. And now a slow process that takes years and decades to cause substantial clinical disease starts. And the first thing that happens is these particles start to adhere to one another. It's called LDL adhesion or ApoB particle adhesion. And as they're doing that, the surface phospholipids are actually changing a little bit, and that's what makes them able to aggregate. And sooner or later, those surface phospholipids are subject to reactive oxygen species that might be in the arterial wall, so they become oxidized. So before you know it, you've got a big mass of cholesterol, some other lipids, the phospholipids, and it's an inflammatory mess. So what happens when our body has pockets of inflammation going on? The innate immune system, trouble. And who goes marching in to put out the fire? Your white blood cells. So in come the white blood cells that once they pass through the endothelial layer, they transform into macrophages, which are white blood cells that can gobble things up to kill it. They're, in other parts of our body, they're killing bacteria to prevent bacterial infections, you name it. But in the arterial wall, these white blood cells pull up to this inflammatory mass, and the white blood cell has all sorts of scavenger receptors, you name it, that can internalize inflamed mass molecules or whatever. So before you know it, this aggregation of particles, ApoB particles, is now internalized into a white blood cell. Over time, as they start internalizing a lot of these molecules, sterile molecules, histologically, it looks like, God, what's all that foam under the microscope? So they got the name foam cells. They're simply cholesterol-laden white blood cells. First time discovered in 1913 by the great Russian Anishkov. He published the first paper showing in rabbits, if you fed them too much cholesterol, what are all these foam cell-like things in their artery wall? So that was the first actually published description. So now these foam cells, over time, again, this is a very slow process, but it's an inflammatory mess. Those white blood cells are secreting chemokines and cytokines, which are just aggravating the inflammatory mess. Further white blood cells are joining the fire. Coagulation starts in the artery wall. The next thing that happens is the external surface of an arterial wall is all smooth muscle cells. That's why an artery can contract and expand. The muscle cells, if they're functional, do that. But our immune system wants to wall off this mess of cholesterol that's accumulating, and it does that by chemo-attracting smooth blood cells. So they move from the external layer and they start surrounding this conglomeration of foam cells. And now you're starting to construct the wall of this plaque that's evolving. And these smooth muscle cells are transformed into tissues that can secrete connective tissue. So before you know it, you have a cap on this plaque. And that's because the immune system wants to isolate this damn thing so it can cause no further trouble, hopefully arrest it so it doesn't keep expanding. But of course, if ApoB particles keep crashing the artery wall, it's futility. The immune system just can't keep up with it. So before you know it, the plaque gets bigger and bigger and bigger, and ultimately starts to either expand in an outward direction in most cases, but in some cases in an inner direction towards the lumen of the artery. And that's at a point where the plaque might actually start to cause obstruction to the flow in the artery. Now, years ago, before we had any therapy, again, it took decades to happen, the lumen of the artery will become more and more narrowed, and before you know it, you just totally obstructed the lumen with plaque. No blood could get through. The tissue beyond the blockage would infarct, would die, a myocardial infarction, or a stroke in the brain. Nowadays, usually the plaques don't get that far because, people are on somewhat better diets today, and many of them are getting lipid-lowering drugs. So you don't have that plaque totally obstructing the artery anymore. That's pretty rare. But unfortunately, what can happen if that plaque that's sitting in the wall of your artery, not obstructing blood flow whatsoever, because it is inflamed and it's like a pustule, I always go, it's like a volcano that suddenly ruptures. Then all the junk within that mass, tissue factors, other coagulation factors, immediately interact with your coagulation factors that are cruising around your plasma, and bingo, you get clot formation within the lumen of the artery. So if I cut your hand, you're probably going to stop bleeding in 3 or 4 minutes, presuming I don't slice an artery, because your coagulation system stops the bleeding. That's why minor trauma, we don't bleed to death. Our coagulation system stops it. But where is the last place you want the coagulation system to really form a clot? In a coronary artery. Most people don't realize the lumen of a coronary artery is like a pencil point. So it doesn't take a terribly big clot to start interfering with the blood flow. So a partial clot, you get somewhat diminished blood flow. That causes ischemia to the tissue where the arteries go. And of course, if you get a total clot, infarct. And this is why the typical heart attack, everybody is feeling well, and boom, 4 minutes later, they're laying on the floor getting a CPR done. That's how quickly heart attacks can cause pathology or kill people. If you're lucky, you're only getting ischemia, maybe you have chest pain, you're smart enough to rush off to the hospital to get a clot buster, and they can save you much better than we could in yesteryear. So in that little description, I've sort of described atherogenesis. It's the invasion of ApoB particles. Now, the Mendelian studies as well as endless epidemiologic as well as randomized clinical trials, have proven ApoB to be causal for atherosclerosis. But it's really not ApoB. If I injected your artery wall with pure ApoB, you will not get atherosclerosis. I have to put cholesterol in your artery wall. But in our bodies, ApoB is carrying cholesterol. You don't have free ApoB floating around your plasma. The ApoB that we exist and measure in plasma, there's one ApoB peptide per beta lipoprotein, as collectively the VLDLs, IDLs, and LDLs are called. So that also makes it easy to measure ApoB in your bloodstream, and you get an exact particle count since there's one ApoB per particle. So yes, you can't separate ApoB from cholesterol. So if you want to say ApoB is causal, I'm all for it, but it's really cholesterol, because ApoB is sort of the skeleton, exoskeleton that's carrying cholesterol into your artery wall. So, and you can't have one without the other. So they're both causal. The last thing I'll say is, what makes an ApoB particle decide to crash your artery wall but not mine, or vice versa? It's pretty much particle number. Depending on other factors, once the ApoB particle concentration crosses a certain threshold, it will invade the artery wall. And then that whole process I've just described starts taking place over years or decades. So the good news, if your ApoB threshold just went a little bit higher than it should today, you're not going to get atherosclerosis for many, many years. But you will get it if you don't stop that ApoB invasion. And we do that in what is now called primordial prevention by measuring ApoB in a routine fashion periodically. And once you have a patient where ApoB crosses that level, you start advising lifestyle, or, depending on the level of ApoB escalation, pharmacological therapies to restore it to a safe, if not a physiological level, if you never want to have the disease. So I'll shut up and let you spin, but I've tried to give you a rapid version of what atherosclerosis is and what the cause is.
That's a fantastic description. So I've actually seen, and maybe many people have seen the graphs where on maybe x-axis, you'll have like ApoB concentration or LDL-C as a scalar, and then on the y-axis you'll have some metric of atherogenesis, whether it's plaque burden or coronary diameter. And at some point, when the ApoB or the LDL-C drops below a certain level, you can have plaque regression. And correct me if I'm wrong about that, but is that threshold, I'm using the word threshold because you mentioned it, does that change depending upon other risk factors? Like, for example, if someone has in mind that they want to reverse coronary plaque, how are they going to know what that threshold is approximately? And when I say other factors, I'm assuming like metabolic dysfunction, insulin resistance, that kind of thing.
Yeah, well, there's two issues in what you just described. There is threshold concentrations at which atherogenesis will start to occur. But if you show up to have me as your clinician and you're 40, 50 years old, you've had these escalations for years, what is the goal of therapy? How much do I have to reduce your particle concentration that I can say you're not going to have a heart attack? Or if you'd like plaque to regress, if you feel that's important, at what level you have to get it to. So we certainly know if we want to look at the threshold level at which atherogenesis occurs, it's an LDL cholesterol of 40. And we know that because of the studies you just described that both either look at plaque or plaque imaging via many imaging modalities that show us, but we also have the same studies using the randomized clinical trials at what ApoB level do people start getting heart attacks or so. And it's really above 40 milligrams per deciliter. Now, again, if you have an LDL cholesterol of 50, okay, you might be subject to atherosclerosis, but it's probably going to be when you're 70 years old. It's not going to be when you're 14. Whereas if you had an LDL cholesterol of 280, it might be when you're 10 years old that you're going to have atherosclerosis. But once your ApoB is high, and we, through whatever risk equation we're looking at and say, oh my God, you're at risk for an atherothrombotic event, at what level do we have to drop you down to? Well, if we really want a plaque to regress, it should be the LDL cholesterol of 40 again. But for clinical events, the rule is, in using those same graphs that you are describing, is if you can drop somebody's LDL cholesterol by 40 milligrams per deciliter over a 10-year period, you will significantly reduce their events. Now, if you want your plaque to disappear on an imaging, then I probably do have to take your LDL cholesterol down to 40. Maybe not even possible if you come to me at age 50, but we'll certainly be reducing events. And that's why I like to say, do you really care if I regress your plaque or not? If I could just guarantee you're not going to have a heart attack or a stroke, or a bypass, a stent, that's the only thing that should matter to you. Are you running around showing your relatives what your angiogram looks like? Look at my plaque. It shrunk by 3/100ths of a millimeter. No, you would like to know that. So that's where the clinical trials tell you, get your ApoB, get your LDL cholesterol down to this level, and you're probably not going to be a worry. But we do know from the studies, because there are genetic conditions where people just have very, very low ApoB or LDL cholesterol. The name is hypo-beta lipoproteinemia. You have very few ApoB-containing particles. You got more than enough to do whatever ApoB particles do, so you're healthy and you don't suffer any consequences because of your extremely low ApoB or LDL cholesterol. But most of us are not born with those type of genes that confer hypo-beta lipoproteinemia onto us. So normally by about the age of 5, most people's ApoB is higher than 50 milligrams per deciliter, a little sooner in some people, depending on both genetics and lifestyle. But by the time you're an adult, your ApoB is probably approaching 100 milligrams. I mean, by adult, I'm saying age 20 in many people or so. And that's really above the threshold that can cause atherogenesis. And that's why there's any number of studies that tragically came out of the Vietnam War, the Korean War, where soldiers who had their demise on the battlefield were autopsied, and the pathologists doing the autopsy were shocked that these people, my God, they have coronary artery disease. Now, they weren't running around the battlefield having chest pain. They had this subclinical atherosclerosis that I described early on. We can also give you a longitudinal, beautiful graphic of an artery wall over time. At birth and through the many early years of childhood, your artery lumen is wide open. Even if you're looking at the intimal layer, it's just a thin layer of connective tissue, a normal endothelium, and that muscularis external level. But at a certain time, before these soldiers get to be 20 and they're dead, with the proper imaging, or God forbid an autopsy, you start to see baby plaque, less baby plaque, more plaque, and it just slowly progresses over time. So here's the definitions now I use. So if I could get an image of every human early in life and I see zero plaque, a perfect artery wall, that is primordial prevention. I would like to keep the artery that way, and I'm probably just going to suggest they don't eat certain stuff, get exercise in their life, avoid some other issues that may irritate the arterial wall, smoking being high on the damn list. And then at a certain point, what if I say, there is minuscule intimal thickening? That can be diagnosed easily on a carotid ultrasound where they start to describe intimal thickening, but they don't see plaque yet. That is what I call maybe primary prevention. Once you see some plaque, where there is a plaque on an image or so, that to me is secondary prevention. In the old days, we used to say secondary prevention is you've had a heart attack, now we don't want you to get a third heart attack. So now, because of all our sophisticated imaging, which are so readily available, so primordial prevention, primary prevention, which is basically your ApoB level is too damn high, maybe I see some intimal thickening. But once I see even more substantial intimal thickening, or God forbid a plaque, coronary calcium, that's secondary prevention. if I could do an autopsy on you, I'd see what the pathologist saw in the Korean War. Oh my God. Subclinical plaque. And of course, if that plaque ruptures, that little volcano I talked about, but you're lucky enough to survive it, now we're into tertiary prevention. I don't want you to have another occlusion because you might not be so lucky with the tertiary. So, you're starting to see that appear in the literature: primordial prevention, primary prevention, secondary prevention, and tertiary prevention. And the good news is, even if you show up because you have been lucky enough to survive a heart attack or a stroke, if you follow all the aggressive regimen you will need, we can drastically reduce the next heart attack or stroke. Far better to get diagnosed before you have the first one, and we can arrest it. If we did arrest it and arrest it aggressively, and we're following these images, and especially if we were doing sophisticated imaging, which is CT angiography, we're not putting a catheter in your artery, but through high-resolution rapid CT, we can section the artery and really pick up plaque in its infancy. You might see it disappearing a little bit. And we'd all be happy to see that if that was our arteries. But does it really matter? How about if we just stabilize your damn plaque and prevent that little volcano from erupting, you're not going to visit the CCU. You're not going to need a stent put in your artery. You're not going to be pronounced or CPR'd. So, but everybody's, how can I regress it? Just get your damn ApoB down to 40, and that's how you can both regress it and surely pretty much guarantee if you can keep that ApoB 40 for a decade or more, you're not going to the CCU, at least for an atherosclerotic reason. So I hope that explains what you're looking for. So
very much, and that helps.
We've got to keep ApoB below those very aggressive levels. And this is a dilemma. Does that mean everybody who somehow discovers their ApoB is high, they have to get on 4 drugs to make their ApoB 30 or 40? No. That's where we start applying other factors into play. So if we had 2 people with whatever ApoB you want to apply to them, is one a little bit more of an atherosclerotic nightmare than the other? Surely. As we start to add other either risk factors or risk modifiers, the longer that list is, the more we respect a given ApoB level. So if on top of your ApoB, the 2 other causal risk factors are smoking and hypertension. So obviously you'd be a nitwit if you were treating lipids and ignoring blood pressure, or not telling a person they have to stop smoking. That will get you nowhere fast. But if they do stop those, then we jump on to what we call risk modifiers. Risk modifiers are perturbations that are associated with atherosclerotic risk, but not causal by themselves. And that would be a subclinical inflammation, diabetes, glycemic abnormalities, things like that. So we would certainly address them, and we have enough studies that if you really blow away ApoB and you also address those other factors, you get additive risk event reduction events, MACE. So there's a lot of things to chase. And you could do the standard risk factors, which are diabetes, renal function, things like that. And but I think advanced people like myself, those who are into really knocking off health span as somebody ages, we look at every possible risk modifier. So then you're going beyond the standards and you're looking at homocysteine and things like that, other vascular irritants that can be at play, and maybe attacking them also, other known causes of endothelial dysfunction.
So yeah, that really helps to clarify the kind of the interaction between some of those other risk factors like smoking, blood pressure, insulin resistance. I'm pretty blown away when you see the risk factor plots of your risk factors for heart attack at some point epidemiologically. It seems like metabolic syndrome in particular is off the charts. Diabetes is off the charts. And I've always wondered why that is. Maybe have some insight mechanistically. maybe that'll actually tie in with can you tell us about some of those other markers that if you have a patient in front of you, is there a batch of tests that you think everybody should be getting? Like if you're in charge of the U.S. Preventative Services Task Force, what would you have everybody get?
If I was in charge of them, they'd fire me in a big hurry because I would bankrupt the country if every citizen had to go out and get the tests I'm looking at. And that means somebody has to pay for them other than perhaps the citizen themselves. By the way, in the list of causal things, I was neglectful not to mention the most prevalent genetic cause of atherosclerosis, which is a different type of LDL particle called lipoprotein(a). That is an LDL that another ectopic protein has jumped on, and you have to inherit the genes that make your liver synthesize that other protein that turns an LDL into a particle that is 6 times more atherogenic than a regular LDL particle by itself. So maybe we can talk more about LP-PLA later, but that's in the causal risk factors too. Right. So on the other things, you mentioned the diabetes and metabolic syndrome, and that is a whole metabolic stew of God knows what. I don't even think we understand all of the perturbations that are floating around that person's plasma. Too often, and unfortunately, everybody thinks, oh, it's just the high sugar. Well, the high sugar is no good over many years also. You can glycolate things and make them more injurious type of whatever. But it's not, high blood sugar is like the last stage of diabetes. Long before the glucose ever crosses some threshold to diagnose pre-diabetes, 100 milligrams per deciliter, or type 2, 126, you got all sorts of things that have been going on for decades. And starting early on is your lipoproteins start to change. I described, hey, we got VLDLs, LDLs, few IDLs, and there's some HDLs floating around. But within each of those groupings of the beta lipoproteins, the LDLs and the VLDLs, they're heterogeneous collections of different types of VLDLs and different types of LDLs. IDLs we can forget, they're a minority particle that are sort of a transition between some VLDLs and LDLs. But there are certain VLDLs that are way more atherogenic than others, and there are certain LDLs that particle for particle might be more atherogenic, but at the end of the day with LDLs, it always comes down to particle number, not some of the, what I call LDL quality, some other things that might be going on or so. So early on, the first metabolic perturbation that really occurs is your lipoproteins start taking a shift to the type that's more likely to wind up in your artery wall than if you didn't have the perturbations of whatever the metabolic disarray is with diabetes. All right. So basically it comes down to there's too much fat in your damn system. Now, it might not be in your belly. At a certain point, it usually is obvious there, but long before you'll see your waist size expanding, that fat is building up in the liver. That fat is in your intestine. Your intestine is making a lipoprotein called the chylomicron, which sends triglycerides into the muscles. Your liver is secreting lipid particles surrounded by ApoB, both VLDLs and LDLs. The liver makes both. Not every LDL is the son of a VLDL in plasma. So what could be going wrong with those particles that might change them or so? So we know that if all of a sudden any of these particles become triglyceride rich, they are going to have a much longer plasma residence time than they would have if they weren't triglyceride rich. So if any ApoB particle has a longer plasma residence time, that means how long does it exist in plasma before it gets cleared? And once it's cleared, it can't hurt you. We're talking about liver clearance. So if any ApoB particle has an increased plasma lipoprotein or plasma residence time, at the end of the day, what is that scary metric that's going through the roof? ApoB. If your particles are circulating longer in plasma, your ApoB concentration is going to be much higher and higher and higher. And it's going to cross that threshold where arterial wall invasion occurs. So the part of the particle perturbations that we start to see, and these are easily analyzable using nuclear magnetic resonance, is all of a sudden VLDL diameter is increased. If VLDLs come in three sizes, big, medium, and small. If you have a physiologic triglyceride level, and I'm talking about hepatic triglyceride, you will never make a big VLDL because the liver is not putting excess quantities of trigs in your VLDL. But if you got a fatty liver, the liver has got a choice to make. Die from fatty liver or ship the damn fat out. So the liver starts stuffing VLDLs with trigs. So you make bigger and bigger VLDLs. Secreted. Once they're out of the liver's going, hey, God, I got rid of that trigs. They can't hurt me anymore. Except the liver doesn't know what's going to happen. So we can measure VLDL size, but if we were also measuring VLDL particle concentration, VLDL-P, and we were doing it using nuclear magnetic resonance, we could actually get a large VLDL particle concentration, a medium VLDL, and a small VLDL-P. If you add them all up, that would be total VLDL-P. But the only thing that goes out of whack with insulin resistance early on is you will be seeing VLDL diameter is much bigger than it should be, and the number of large VLDL particles are increased. If I ever got on a 5-year-old an NMR report back that showed large VLDL particles, and that kid didn't have a genetic triglyceride issue, I would know, God darn it, this little guy is developing insulin resistance. But it's not only the VLDLs that change. When the VLDL that's full of trigs is now floating in your plasma, the VLDL starts shipping its triglycerides to other circulating lipoproteins, and that would be LDLs and HDLs. We actually have a lipid transfer protein that sort of tries to equalize the core lipids in our particles a little bit. So the VLDL carrying extra trigs says, I want to get rid of those trigs using CETP, cholesterol ester transfer protein. It sends the trigs either to LDLs or HDLs. To make room for the trigs, the LDLs or the HDLs send one molecule of cholesterol back to the VLDL in exchange for one molecule of triglycerides. Now, if that keeps happening over the increased plasma residence time of these particles, what happens? The VLDL becomes more cholesterol rich, triglyceride poor. The LDL becomes triglyceride rich but cholesterol poor. The HDL likewise becomes triglyceride rich and cholesterol poor. By the way, physiologically, HDL should never carry any triglycerides more than a molecule or two. They were not created to traffic trigs. The Lord, evolution, gave us VLDLs and kilos to traffic trigs to the muscles. All right. But now all of a sudden, you have triglyceride-rich LDLs and triglyceride-rich HDLs. Triglycerides attract specific lipases that hydrolyze, dissolve the triglycerides. So as the LDL is cruising through the liver circulation, on the surface of the liver is an enzyme called hepatic lipase, which hydrolyzes the triglycerides in the LDL. But remember that LDL is cholesterol poor now. So envision I have a big fat triglyceride-rich cholesterol poor LDL, but now the liver is hydrolyzing the trigs via hepatic lipase. The LDL becomes smaller. By the way, in a centrifuge, if a particle becomes smaller, it becomes denser and it sinks to the bottom of the tube. So as you send trigs to an LDL and make it transitorily big and fat with trigs, but it rapidly loses those trigs due to lipolysis at the surface of the liver, you've changed that LDL into a small, dense LDL. That's a stupid redundancy. We either should just say small LDLs or dense LDLs. You don't have to say small, dense. By definition, any lipoprotein that is small and is dense, any dense lipoprotein, by definition, is smaller than its brothers and sisters. Right. So if I were doing that NMR study early in life, not only would I see big triglyceride diameter, and I'd see increased large VLDL particles, but now I would see decreased LDL diameter and increased small LDL particle count. By the way, if you increase the small LDLs, since LDLs make up 95% of the ApoB population, what do you think you're doing to total LDL particle concentration, or ApoB? When you generate small LDLs, you are sending ApoB through the roof. So the danger is not really because the LDLs are small. It's just, holy God, you got too damn many LDLs now. All right. Same thing happens to HDLs. And HDL should never carry trigs. So once it's a fat triglyceride devoid of cholesterol, both hepatic lipase, and there's another lipase that loves HDL particles called endothelial lipase, you have hydrolysis of the HDL trigs. So imagine an HDL that's triglyceride rich. Dan Rader used to call them fat HDLs because they shouldn't have trigs. But I now hydrolyze the trigs via those enzymes I just mentioned. What would happen to the HDL? It becomes a small, dense HDL. So if on that same NMR test, I am measuring HDL diameter or I'm measuring the number of large HDLs, I would see, oh my God, HDL diameter is much smaller than it normally is. And I don't have any more large HDLs because they don't exist anymore. The only HDLs I have are small HDLs. By the way, what do you think would happen to HDL cholesterol during that process? It would disappear because the small HDLs are only carrying a few molecules of cholesterol per particle. I think I've just described in a gross sense what are the lipid parameters with the metabolic syndrome? High trigs, low HDL cholesterol. Now you know why. The HDL cholesterol is down because trigs invaded the HDL and they became small HDLs that don't carry cholesterol anymore. But what is the real danger to that situation? You have way too many ApoB particles, which are mostly small LDLs. But the VLDLs that are left, they're smaller now because they've lost trigs, but they've acquired cholesterol. What is a small VLDL that is cholesterol-laden called? A VLDL remnant, a chylomicron remnant, recognized to be among the most atherogenic of particles that exist. So you could see, oh my God, these lipoprotein changes that occur years before even postprandial insulin starts to go up, and decades before insulin or even glycemic abnormalities occur. If we were only doing advanced lipoprotein analysis early in life, we would pick up insulin resistance in its infancy. Now, again, not everybody's doing that. Not everybody has the knowledge to interpret that if they got those report back, and there is cost with doing that. And that's why we focus on trigs and HDL cholesterol as the lipid signatures of insulin resistance. But those lipoprotein changes I just described, do you know at what serum triglyceride levels they occur? Do you think it's like 150, which is defined as high trigs now? No, pretty much above a serum triglyceride of 70 to 100 milligrams per deciliter. Those perturbations in the lipoproteins occur. So what happens if we were measuring trigs in that young person? We tell your trig is 100, 110, 85. Don't worry about it. Whereas if we were doing lipoprotein analyses, we'd say, holy God, you're in big metabolic trouble. The other thing that's going up, even sort of when the insulin starts to sneak up, after the lipoproteins become abnormal, is blood pressure starts to subtly rise above the 115 mark systolic, above the 80 mark diastolic. And tragically, even blood pressures of 125 over 86 are ignored nowadays, and that's a rather pathologic blood pressure. And if I saw blood pressure like that, the first thing on the top of my mind, am I dealing with insulin resistance? Most likely you are. That's the most common cause of hypertension nowadays. And the very best news, if you were doing those super lipoprotein tests I described or respecting subtle blood pressure, that's where lifestyle can just pretty much arrest the darn process, you know? And if they did lifestyle and it didn't correct, then it's time to jump in maybe with some sort of pharmacological approach. But again, the earlier you discover this, the earlier it is to correct in a more reasonable way. So, boy, I blabbered for a long time there, but I wanted to give you an insight into the pathology that occurs. So it's lipoprotein abnormalities, postprandial insulin, fasting insulin, and then glucose perturbations. If you're waiting for glucose perturbations, those arteries have had decades of dealing with an atherogenic milieu. And that's why it's stupid to wait for glycemic abnormalities to panic. And what's maybe even more sad, few people even panic when they see glucose of 110 or even, whoa, it's 130, you only have a touch of diabetes.
Yeah, I often wish that I had a time machine in the emergency department. When I see a patient land in front of me, I kind of rewind 20 to 30 years ago, and if there was just something that someone could have said at that time, right, like to modify their risk, because I think often it's taught, even in medical school, there's, you know, at least when I went to medical school, they're not really looking for early signs of insulin resistance. They're kind of just waiting until glucose gets totally out of whack before, you know, we hit any kind of intervention button.
Yeah, totally.
So,
when I went to med school, we were waiting for diabetic coma to worry about it. So we've come a long way.
Well, I guess from that perspective, we have come a long way. Wow. That's incredible. How does homocysteine, I have two particular ones I wanted to ask you about, actually. Homocysteine and LP-PLA2. You see those float around a lot. How do those fit into all this?
Well, homocysteine, basically, if you want a one sentence, it's an endothelial irritant. Homocysteine shuts, and we could go through the metabolic steps, and there's no need to that for this type of podcast, but it pretty much hinders nitric oxide production in the blood vessel wall. And endothelium has a lot of functions, but its main function is probably the production of nitric oxide, which is so crucial for arterial health. You scrub nitric oxide, you're creating arterial pathology in its earliest form. So if we could keep homocysteine physiologic, that's one way of improving endothelial health. So now LP-PLA2 is an interesting biomarker, lipoprotein phospholipase A2. And it's an enzyme that was very intriguing because I told you when those particles enter the artery wall, those ApoB particles, at a certain point they start getting oxidized, and that's what sets off the real inflammatory mess. That's what recruits the blood cells to gobble up the sterile-laden ApoB particles. So how do those particles get oxidized in the artery wall? So they enter the artery wall, and now you have a particle that's there. It's trapped. The ApoB is what's binding it to the arterial wall proteoglycans. But what does the vast surface of that trapped particle consist of? Phospholipids and free sterols, mostly free cholesterol. So ApoB takes up a very tiny part of the surface area that's there. So those phospholipids that are sitting there are ready to let the immune system do something to them. So what happens is there's an enzyme that's carried on these particles called lipoprotein phospholipase A2. So what is that? Think of what it says, lipoprotein. So this is an enzyme that's carried on a lipoprotein, and the enzyme is called phospholipase A2. So a little bit of biochemistry here, if you don't mind. What is a phospholipid? A triglyceride that everybody knows are how fatty acids are transported within lipoproteins. You take a 3-carbon sugar called glycerol, and you esterify it with 3 different fatty acids. Esterify means stick a fatty acid on something. So here's glycerol, 3 OH groups, but you lose the OH groups and 3 fatty acids bind. There's carbons 1, 2, and 3. Those carbons retain those numbers, 1, 2, and 3. That's what a triglyceride is. What's a phospholipid? It's actually in the same class of lipids as a triglyceride. The real name of triglyceride is triacylglycerol, 3 acyl groups, fatty acid on a glycerol backbone. It's the major lipid in a class of lipids called glycerolipids. So who else belongs to the glycerolipids class? Well, a glycerol molecule that doesn't have 3 fatty acids attached to it, it's only got 2 fatty acids attached to it. And that's what a phospholipid is. But wait a minute, there's 3 carbons. What's attached to the 3rd carbon in a phospholipid? It's a phosphorus moiety. So it's this phosphorus compound, which could be this big or this big. It's not shown on the camera, very big. That's going to depend on the length of the fatty acid chains that are esterified to the phosphorus moiety. So you have a phosphorus head group with 2 fatty acids. All right, but 1, 2, and 3. The phospholipid is going to attach to carbon 1, and then you have the 2 fatty acids on carbon 2 and carbon 3. For the geeks in the audience, they're not really called carbons 1, 2, and 3. They're SN 1, 2, and 3, stereospecific numbering. You don't have to know that, people. So now we have enzymes that can deesterify a glycerolipid. So when VLDLs and chylos show up at a muscle or adipocyte bed, the triglycerides are going to be hydrolyzed because those tissues want the fatty acids. So is there an enzyme that hydrolyzes 3 fatty acids off of a glycerol? Yeah, it's called lipoprotein lipase, LPL. It's a triglyceridase. Boom, you lose the 3, you convert triacylglycerol back to glycerol. Okay. Now, but phospholipids, is there enzymes that deesterify phospholipids? Yes. And they would be called phospholipases. Surprise! Not a triglyceridase, phospholipase. But there are any number of phospholipases. So, what if you had a phospholipase that was engineered to hydrolyze the fatty acid at carbon number 2? I guess we would call that phospholipase A2. Right? So, now you asked me about LP-PLA2. So obviously that is a phospholipase that's going to hydrolyze the fatty acid at the 2nd carbon that's on a lipoprotein. So if LP-PLA2, which is trafficked by LDL particles, starts attacking the phospholipids on the surface of the particle, what are the byproducts of taking out the fatty acid at carbon number 2? You're left with a phospholipid that has 1 fatty acid at carbon 3, a hydroxy group at carbon 2, and the phosphorus moiety at carbon 1. So it's a 1-legged fatty acid phospholipid. We call them lysophospholipids. So now, if on a lipoprotein particle, the most common phospholipid on the surface of lipoproteins is lysolecithin. Lecithin is the phospholipid. So if you hydrolyze lysolecithin with that enzyme, you are left with lysolecithin, and you're left with a fatty acid that's not carrying a hydrogen group because it got cleaved off. That's an oxidized fatty acid. So what that enzyme does is create oxidized fatty acids and lysolecithin. By itself, lysolecithin is known to be atherogenic. So, holy Christ, that enzyme turned the sort of an inert sort of particle, it's just trapped in the artery wall, to letting it start to release very atherogenic constituents of the particle that was on the phospholipid that was on the surface of the particle. So that sounds like a bad enzyme to me. So, and it sounded like a bad enzyme to a lot of researchers many years ago. And that led to pharma saying, oh my God, if we could just inhibit phospholipase, meaning if we could find a phospholipase inhibitor, we would basically shut down steps 2 or 3 of atherogenesis, and that would work. So they Didn't take them long to invent a couple of phospholipase inhibitors, and 2 of them were subjected to big, randomized, blinded, controlled outcome studies. And they basically lowered LP-PLA2 to non-detectable amounts because you were inhibiting the enzyme. And guess what they did? They didn't reduce one heart attack. So that's when we knew that LP-PLA2 is not a risk factor, it's a risk modifier. But we also know if you somehow negate a risk modifier, if you're not taking out the risk factors, you don't reduce any atherogenesis. So boy, oh boy, was that a bust for pharma. Another $1 billion down the drain on drugs that should have worked but didn't work. Didn't cause any harm, but they just didn't reduce major atherosclerotic cardiovascular events. So if you're measuring LP-PLA2 in your patient's bloodstreams, fine. It's an inflammatory, serves its role as an inflammatory marker that is a risk marker for atherosclerosis, but under 0 circumstances is it a goal of therapy. And yet doctors still use it as a goal of therapy because many of our lipid modulating drugs do lower LP-PLA2, and people say, oh, I got to get it to a goal. There is no goal because we eliminated it, LP-PLA2, and it didn't reduce a heart attack. So you can use LP-PLA2 as a risk marker, but I don't think you should ever repeat it if they're on lipid-modifying drugs and think that it's giving you any useful information. Even statins lower LP-PLA2, but statins work because they're lowering ApoB, not because of what the hell they're doing to LP-PLA2. And I always say, look, nowadays, if you want an inflammatory marker, you got HSCRP, which has 50 times more data. It also is a risk marker, but it's just easier. Just use that if you need a risk marker. So LP-PLA2, as far as I'm concerned, is of no concern. But I got to teach you more, because when they first started measuring LP-PLA2, first they measured LP-PLA2 mass, and after X amount of years, they said, no, we got to measure LP-PLA2 activity. That's more important. And all the assays nowadays are measuring activity. Nobody's measuring mass anymore. Turns out they're both equally predictive, and neither can serve as a goal of therapy. But if I asked you off the top of your head, I've already hinted that it's on LDL particles, LP-PLA2. Really? What lipoprotein in your body would you find most of that enzyme attached to? And here's what it is. So you have the LDL family. You have big LDLs, you have small LDLs. But is there another type of LDL? Yeah, LP-A, which is an LDL particle that has an ectopic protein attached to it, apoprotein-A. So here's the rule. A large LDL carries a small amount of copies of the enzyme LP-PLA2. Many, many, many more copies are on the small LDLs. Some people are now saying, for those who are promulgating, that small LDLs are more atherogenic than big. Of course, they carry more LP-PLA2 than the big particles. All right. Yeah. And they somehow neglect that your total LDLP is through the roof, which really explains the danger of small LDLs. But you want to know the particle that you'll find 90% of your LP-PLA2 on? LP-A particles. In fact, if you came to me today and I was measuring LP-PLA2 and I'm doing a lipid profile, but I do that, but I didn't check an LP-A on you, and your LP-PLA2 comes back through the roof, I ought to immediately send you over to the lab to get an LP-A level, because that's likely what. So it's almost a marker of LP-A.
Interesting.
And remember, LP-A is oxidizing what? Phospholipids. And what is the number one carrier in the bloodstream of oxidized phospholipids? The kringles that make up apoprotein-A. Apoprotein-A consists of a bunch of looped amino acids that are called kringles. And there's one specific kringle, kringle 10, that carry, kringle 4 subtype 10, that carries oxidized phospholipids. If I had two people with high LP-A, one has a high LP-PLA2 and the other one doesn't, I should be a lot more worried about the one who has the high LP-PLA2. But you know what? You shouldn't even measure that anymore because there's a more specific assay, and it's called oxidized phospholipids on ApoB. And now you're measuring the oxidized phospholipids that are, there's a few of them stuck to the ApoB peptide. There's a few of them stuck to the surface phospholipids of a trapped LDL particle, but most of them are on the Kringle subtype 410 and LP-A particles. And that makes apoprotein a or the whole LP-A particle incredibly more atherogenic than an LP-A that's not carrying oxidized phospholipids. It is now believed the primary atherogenic liability of an LP-A particle is its content of oxidized phospholipids. Maybe we even evolved it as a dump truck to gather oxidized lipid moieties, which are very tissue destructive, and get them the hell out of the system. So who knows? But that's where LP-PLA2, it's had a long and complicated history. If you're measuring oxidized phospholipids on ApoB, I see no reasons to, under any circumstances, measure LP-PLA2. Go with CRP.
I know there's pharmacotherapy that can modify, in theory, at least the evidence that we have so far, there's pharmacotherapy that can lower your LP-A by some amount. The exact amount seems to be a little unclear, but is there pharmacotherapy that is able to modify oxidized phospholipids on ApoB?
They believe the new LP-A investigatory drugs that are in development that pretty much shut down hepatic production of ApoA, and there's several different classes of those that are now being tested in clinical trials. Oligonucleotide inhibitors, small interfering RNA, and other drugs that get into the liver and prevent ApoA from binding to LDL particles in the liver. So they see, especially the first two that really shut down ApoA production dramatically, in these lipid studies that have been run up drastically lower the oxidized phospholipids on it. As far as existing drugs that we have available to us now, statins do not. And, so if you have copious quantities of oxidized phospholipids, maybe a statin it's a drug you probably need, but maybe you need some helper drugs with it or so that are yet to be determined. We're in our infancy in studying it yet, so we have a lot more to learn. But the super ApoA drugs that are coming, no doubt, will lower that. And then when they analyze the clinical trial data here, let's say those drugs are successful, and they are measuring oxidized phospholipids. They're certainly in the first trial that's being done with pelacarsen. If pelacarsen works, is it because it's just reducing LP-A, or is it, hey, it's really getting rid of the ApoA particles that are carrying oxidized phospholipids? So we may have a future answer to that question. Right now, we're sort of hoping all you have to do is lower LP-A. Look, if you get rid of those particles, there should be somewhat lesser particles that are carrying oxidized phospholipids. So stay tuned.
So just take out the carrier.
You did hint there is one drug we have available to us nowadays that could lower your LP-A mass or your LP-A particle count, the preferred metric, a bit. Not to the levels that these new drugs are going to lower it, but perhaps to the 25 to 30% range. And that would be the PCSK9 inhibitors that are readily available nowadays, be it the monoclonal antibodies or the small interfering RNA. Does lowering LP-A by 25 to 30% matter, or do we have to eliminate it? Only future trials will tell us that, but post-hoc analysis of the two monoclonal LP-A trials, Ferrier and Odyssey, suggests that even that degree of LP-A lowering, 25%, there is a definite trend towards event reduction. So that would suggest even a little bit of LP-A lowering can do it. Now, look, that's big-time off-label use of those drugs. You can't get it covered by a third-party payer to do that. Even the LP-A testing would not be covered because it's a theory now rather than proven fact. So, and the real problem with saying, hey, just get on a PCSK9 is the cost, and not everybody can afford them. So that's the dilemma with that. So, but I think that we're on our way to certainly lessening the morbidity and mortality of LP-A, presuming those monster drugs coming are also safe. And that's why, that's a big part of the trial. Not only show you can reduce heart attacks, but you don't cause ill effects as the price to lowering heart attacks.
That's a big one for sure. While we're on the topic of PCSK9 and these new novel lipid-lowering therapies, or I should say lipid modification therapies, looking down the horizon like 10, 20 years, what do you see that's in development right now that you think is promising? What are you excited about?
Listen, I've been in lipidology. The world started studying, the clinical world in the mid-1980s started to realize we had a few lipid drugs, and it was even pre-statin, and we started to pay attention to lipids. So I've been in the lipid world since 1985, so what's that, 15, so a long time. If you would have asked me in 1985, Tom, in 25, 30 years from now, what are we going to be doing with lipids? I couldn't have given you a coherent answer. So I don't know that I can give you a coherent answer. After I'm long gone, what are they going to be doing? But I think the thing perhaps of the most excitement now is getting somebody who you define as a very high-risk ASCVD patient decades down the road, an ApoB nightmare, and getting in there with a one-time infusion that will shut down ApoB production to the hypobeta-lipoproteinemia range. And that we can actually do with what's called CRISPR, gene editing technology. So it's a one-time infusion. All of a sudden, your liver cells, and remember, it's being injected, but it's very liver-specific, and liver is the organ that's making 99% of your ApoB. The intestine makes a different type of ApoB. No other tissues are making ApoB. So you couldn't possibly hurt any other tissues unless you're screwing up other genetic things you don't know when you start this. So that's the most exciting thing. Can you imagine? Now, initially, this will be given to little children who have homozygous FH or severe heterozygous FH, because they know, God, they're going to have their heart attacks by the time they're 8, 10, 12 years old. So if you identify them day one, wow, and you could apply that to them, and all of a sudden, you've taken heart attacks, you've survived that kid for going to die of something else, but that's going to be 50, 60 years later. So that would be the biggest hope. I think we're now in, even since we have the siRNAs and the antisense oligonucleotides, I believe the future of almost all disease modification is going to be genetic alterations, not, and look, by studying genes, what we did first study was, these genes control these proteins. Let's attack those proteins. But why don't we just attack the genes that are making those proteins? So that's the stepladder we've been going up since we started doing this. So it's all going to be genetic therapies in the future. And they're going to be easy. They're going to be more affordable. They're going to be pretty safe. Obviously, you have to start testing them with the nightmares of the world to not only prove efficacy, but safety, and then you'll start studying them in people at lesser and lesser risk and see how far you can go with these therapies. You mentioned a vaccine. A vaccine, sort of like you're attacking probably the protein earlier in life, not the genes. But vaccine therapy has been studied for a long time. Now that we understand the proteins a lot better, I don't know where vaccinations are going to take us or not, but that's certainly being studied.
What role do you think exercise has? Is it more of a modification of your overall metabolic health? Or one thing I've heard recently, and I haven't actually found the study to confirm this, is that it's dependent upon the diameter of the coronary artery lumen. So in other words, exercise would cause you to have a larger coronary artery lumen. And because of that, you're more resilient to stenosis. And if a plaque does break off, it goes further downstream. Would you have good evidence for that? Or do you think exercise is the primary thing? Exercise is metabolic?
Makes no sense to me, because atherosclerosis, for its first 75% of evolution is in the wall of the artery. It's not making anybody's arteries narrow. So I think if you want exercise in your life, you should be doing it long before you have a stenosis. So look, I think exercise is an incredible part of good health, lifelong exercise. And why? It combats insulin resistance. You build up muscle mass, which can eat things during your sleeping hours. You have better sleep when you have the muscles and everything. Way down the road, you're going to have far greater stability if you have muscles. I don't believe muscles show any lipid or lipoprotein effect that's liable to make your arteries healthy. They certainly, though, reduce that whole metabolic milieu that is present. Most of us get atherosclerosis nowadays, not because we're genetic hyperbeta lipoproteinemia, some bizarre rare genetic defect, the FHs of the world. It's because we're insulin resistant in today's societies, starting at very early ages. And that's why the only population solution to this is much better nutritional and muscular training in our children. Yeah, I think physical education probably doesn't even exist to any serious degree in early schools nowadays throughout the world. So that's got to come back into play. And then after school, kids can't be going home and playing on their iPhones. They got to be out there doing strengthening exercises as well as aerobic exercise. And far be it to me to pontificate of what type of exercise, but I think you got to do that early in life and everything. Now, look, if you show up with your first bypass, I think exercise can correct a lot of metabolic defects, but it's not going to correct your lipids. If you've survived an event or have serious, you need to be on aggressive lipid modification with your exercise, with your sleep regimen, with your metabolic regimen. And creeping into this, which we've ignored for decades, is the psychological well-being of the human being and all those type of humoral things that are caused by mental stability and less mental aggravation, which affects so many of the hormones and other things in our body. So that's becoming an integral part of absolute total picture of atherosclerotic care and everything. So is mental stability and happiness equal to exercise? They're all pieces of the puzzle. But I don't think doing one piece of the puzzle. Listen, in my life, let's just say I've been consulted by many people. I know of at least 2 gold medal winning Olympians who within 2 years of showing their medal went and had a coronary calcium. That means they're very young yet. And like those soldiers who they autopsied in the Korean War, oh my God, how could I have a positive coronary calcium score? I just won a gold medal. There have been very famous, well-trained people certainly who have either dropped dead on the playing field or get their atherosclerosis discovered. Some of that is they missed the FH in earlier life where they should have. But you just can't look at people who are well built and say you're immune to atherosclerosis. Multifactorial. If you look in the old days, all those athletes who couldn't football smoke like a fiend. So I don't care how you look at it.
You're right. I'm totally right about
or most of them, but
yeah, and I look at even the studies of like what are considered today to be non-modifiable risk factors like LP-PLA. And even in the setting of high LP-PLA, lifestyle plays just a gigantic role. I'm sure you're probably thinking of the same study that I am. They just showed this aggressive risk reduction in a coronary event. I should be careful. I'm not sure if they actually measured coronary events, but it was some outcome measurement of ASCVD.
Look, for those of you who are listening, everybody knows my good friend and colleague Peter Attia has written that incredible New York Times best-selling books, Outlive. Yes, there is one chapter devoted to the heart, but the rest of the book is devoted to everything else, including mental health. Obviously, with Peter, exercise is big, sleep is gigantic, nutrition. So you got to sort of jump out of the lipid world, ultimately. It's a big part of
absolutely.
It can't, by itself, no good.
Yeah, I can't recommend that book highly enough. That was a great one. And I want to thank you, Dr. Dayspring. You know, I've been following your content for a long time. I've learned just an incredible amount from you. And I highly recommend that people go follow you, check you out. How can people find you?
The best way day to day to follow me and maybe even ask me a question, which I'm likely to answer, is on Twitter at Dr. Lipid. I have 37,000 followers, and I'm pretty active on a daily basis. I've made my career through illustrating a lot of concepts dealing with lipids, and I post those graphics all the time. If you're a professional, I would advise you to also follow me on LinkedIn. I call it Twitter. It's X nowadays. Anybody can follow me. I don't have any say. If you're a nitwit, I can block you if I don't like what you're saying. But with LinkedIn, I usually only accept professionals because keep it a little more serious, maybe a little more high level, although I think my Twitter feeds are pretty high level. So that's the best way. And look, you can try messaging me on Twitter. And if you're polite and you're good, I'm pretty good at even responding to people. I shouldn't say that because I might get 2,200 messages.
There you go. There you go. Exactly. Well, we'll link to you on Twitter in the description, and people can find your content there. I highly recommend it. It's always new information, things that I had not known before. Just one of the best educational resources online for lipidology and overall coronary risk. So thank you again, Dr. Dayspring. I really appreciate you taking the time to come on today.
My pleasure, Nick. I loved it.
All right. Thanks again. See you, everyone.